Welcome to the deep dive. Today we're really getting stuck into a core topic for any vascular surgeon.
Absolutely.
Picture this. You're in your FRCS Viva, everything's quiet, the examiner leans forward, gives you a complex DVT case,
Classic scenario.
and then they hit you with something specific, maybe about CDT selection or DOACs in cancer, the latest thinking.
Yeah, the nuances.
Exactly. So today, that's our mission. We're diving deep into the ESVS 2021 Clinical Practice Guidelines on the management of venous thrombosis.
And this isn't just, skimming the surface. We're aiming for a consultant-level chat here,
Yeah.
giving you the evidence, the rationale, everything you need for that exam, and, well, for your actual practice. Think
Yeah.
of us as your guides through the thicket.
That's right. And these guidelines, they're not just exam fodder, are they? They're really the foundation of what we do every day in vascular practice.
They absolutely are. They give you that pragmatic, evidence-based structure. It's basically distilling tons of research into, actionable advice.
And honestly, getting your head around these properly, it directly impacts how well you treat patients, and it sharpens your ability to look at evidence critically. That's a key skill.
Couldn't agree more. And before we jump in, it's only right we acknowledge Dr. Clive Kieran. His work in VTE was immense, profoundly shaping these guidelines. They're actually dedicated to his memory.
A true giant in the field. Okay, so thinking about these 2021 guidelines, what are the really big shifts? What's changed from, say, 10 years ago?
Well, the most obvious one, the one you see every single day, is the huge role of DOACs, the direct oral anticoagulants.
Right. They've really taken center stage.
They really have. They're not just an alternative anymore. For many, maybe most, DVT situations, they're now first line, pushing VKAs down the pecking order.
That's a fundamental change in how we start treatment. And what about interventions? I feel like the approach has become more selective.
Definitely more selective. Things like catheter-directed thrombolysis, CDT, and other early clot removal techniques. The guidelines push for a much more nuanced approach.
So not for everyone with a big DVT.
No, absolutely not. It's really reserved for specific cases, usually those extensive iliofemoral DVTs where the potential benefit, you're preventing severe long-term problems, might outweigh the risks. It's very targeted.
Okay. And compression, always a hot topic.
Yeah, compression therapy has been reevaluated too. Its role in the acute phase, and especially in preventing post-thrombotic syndrome, or PTS. There's more emphasis on starting early, but also tailoring the duration, not just wear these for 2 years.
Right. Individualizing it more.
Exactly. And then there's cancer-associated thrombosis, always a tough one. The evidence comparing LMWHs and DOACs keeps evolving there. It's a constant balancing act, risk of clotting versus risk of bleeding in a really vulnerable group.
It really is. And one thing I really like about these guidelines is how they've tried to bring in the patient perspective,
That's important.
especially around things like compression or deciding about thrombolysis, acknowledging that even small benefits need discussion, that shared decision-making is key. It's not just about the trial data.
Absolutely. That dialogue, making sure the patient understands the why, is just as vital as picking the right treatment based on the evidence. It improves the whole experience. #TAGNESS. Diagnosis and risk stratification.
Okay, let's ground ourselves in diagnosis and risk stratification. This is square one for any DVT workup. So patient comes in, classic swollen, painful leg. What's the first step in your assessment? And crucially, what's the role of the Wells score? Because you will get asked this in the Viva.
Oh, guaranteed. First up, it's always a good clinical assessment. History, examination, looking for that unilateral swelling, the tenderness, the redness. But as we know, those signs can be pretty non-specific.
Right. Lots of things cause a swollen leg.
Exactly. And that's precisely where the Wells DVT score is indispensable, right at the start. It helps you estimate the pretest probability. How likely is this actually DVT before you do any tests? It helps guide your next move. There's the simple version. Score 2 or more, DVT likely. Less than 2, unlikely.
And the 3-category one, too.
Yeah, or the 3-level one. Low, moderate, high likelihood. Both are valid.
Can you just quickly run through the main things that give you points on that score? Always good to refresh.
Sure. So you get a point for each of these. Active cancer, paralysis, or recent leg cast, bedridden recently or major surgery, localized tenderness along the deep veins, whole leg swollen, calf swollen more than 3 centimeters compared to the other side, pitting edema just on that leg, and visible collateral superficial veins. Then crucially, you subtract 2 points if you think another diagnosis is just as or more likely than DVT.
Right, so it really helps direct your diagnostic pathway. But, and this is key, it's not foolproof, is it? You can't just send someone home based on a low Wells score alone.
Absolutely not. That's a critical point examiners look for. Even in that DVT unlikely group with a score less than 2, there's still up to a 5% chance they could have a DVT. So a low score tells you the probability is low, and that lets you use D-dimer safely next, perhaps. But it doesn't definitively rule it out on its own as part of an algorithm.
Okay, perfect distinction, which leads us neatly on to biomarkers and imaging. Let's talk D-dimer. What is it fundamentally, and what are its strengths, and maybe more importantly, its weaknesses?
So D-dimer, it's essentially a breakdown product of a blood clot. When a fibrin clot gets formed and then broken down by the body's natural clot-busting system, D-dimer gets released. So levels go up when there's significant clotting, like in DVT or PE.
And its big strength.
Its big strength is its negative predictive value. It's fantastic as a rule-out test. If you have a low or intermediate well score and the D-dimer is negative, you can be very confident that the patient doesn't have a DVT.
But the downside?
The downside is its terrible specificity. Loads of things can make D-dimer go up: infection, inflammation, cancer, recent surgery, liver disease, even just getting older. Age-adjusted cutoffs help a bit, especially in older patients, but it's still often positive when there's no VTE. So a positive D-dimer often means you need imaging, even if it turns out to be negative. Great rule out, poor rule in.
Good summary. So if the D-dimer is positive or the Wells score was high to begin with, we move to ultrasound. Now, there are different ways to do the scan, right? 2-point compression versus whole leg.
Yeah, mainly two approaches with ultrasound. US, 2-point compression ultrasound. CUS is quick. You just compress the main veins at key points, common femoral, popliteal. It's good for picking up symptomatic proximal DVTs, the ones higher up the leg.
But the limitation is?
The limitation is it doesn't look at the calf veins properly. So it can miss DVTs that are isolated down in the calf, distal DVTs.
Which is where the whole leg scan comes in.
Exactly. Whole leg ultrasound, WLUS, scans the entire deep vein system right down through the calf veins, peroneal, tibial veins. The guidelines, recommendation 6, really push for WLUS if you suspect a calf DVT, or if the picture's unclear after a CUS, precisely so you don't miss those isolated distal clots. We'll talk more about why missing those might matter later.
Okay, so let's say you've done the Wells, the D-dimer, the duplex scan, but maybe things are still uncertain, or you suspect involvement higher up in the pelvis. When do you start thinking about imaging beyond ultrasound? What about CT venography, MR venography, maybe even traditional venography? That sounds like a classic Viva question right there.
Definitely a Viva favorite.
Yeah.
For most DVTs, duplex ultrasound nails it. But yes, there are situations where you need advanced imaging. First, computed tomography venography, CTV. It's very good, similar accuracy to ultrasound for proximal DVT. Its real strength is visualizing the pelvic veins and the IVC, which ultrasound can struggle with, especially in larger patients.
Right.
Plus, it can spot other things causing symptoms like a tumor pressing on a vein. And it's great for planning interventions like stenting because you get precise measurements.
Downsides.
Downsides are cost, the need for iodine contrast allergies, kidney issues, and radiation. That's a particular worry in younger patients.
Okay. And magnetic resonance venography, MRV, how does that compare?
MRV is generally comparable to ultrasound in accuracy, though it varies a bit with the technique used. Its niche roles are often in follow-up, trying to tell if a clot is old or new, which duplex isn't great at. Some MR techniques can even help age the thrombus.
Interesting.
And it's useful if someone can't have iodine contrast or radiation, but it's expensive, takes longer, and isn't as widely available.
And the old gold standard, traditional venography, is that ever done now?
Very, very rarely just for diagnosis. It was the gold standard, but it's invasive, uses contrast, involves radiation. So mostly you'd only see it now if other tests are totally inconclusive, or more commonly, if you're planning an intervention like stenting at the same time. It helps guide the procedure.
Makes sense. Okay, shifting gears slightly. Screening for occult conditions. DVT can be a warning sign. What about routine screening for occult pulmonary embolism, PE, in someone with a new DVT? Should everyone get a CTPA?
That's a common question. We know maybe 30–40% of DVT patients do have a silent PE, especially with proximal DVTs or in older folks.
Right, so should we look for it?
The ESVS guidelines, recommendation 7, say no to routine screening. The reasoning is practical. The extra cost, the radiation exposure for everyone, and crucially, there's just no solid evidence that finding and treating these silent PEs actually improves outcomes or is cost-effective.
No.
Most probably resolve anyway.
So generally no, but are there exceptions, times when you would investigate for PE?
Oh, absolutely. Clinical judgment is key. If the patient has suggestive symptoms, or maybe new ECG changes, or concerning chest x-ray findings, or maybe you see free-floating clot on the ultrasound, or certain cardiac biomarkers are up, then yes, you'd investigate for PE based on clinical suspicion, not just routine screening.
Got it. What about the other big one? Occult malignancy.
Mhm.
DVT as the first sign of cancer. How hard should we look for an underlying cancer in someone with an unprovoked DVT?
It's a real concern. Somewhere between 4 and 12% of patients with an unprovoked DVT will get diagnosed with cancer, usually within the first year. The guidelines talk about 2 levels of screening, limited versus extensive.
What's the difference?
Limited screening is basically a good history, looking for red flags like weight loss, change in bowel habit, a full examination, basic bloods, FBC, LFTs, renal, maybe ESR, CRP, and age and sex-appropriate screening like PSA in men, mammograms in women, based on national guidelines. Extensive screening adds things like CT scans of the chest, abdomen, and pelvis, maybe colonoscopy.
And the guideline recommendation? Go extensive or limited.
The guideline, recommendation 8, comes down firmly on the side of limited screening over routine extensive screening. Meta-analyses show that while extensive screening finds a few more cancers, it doesn't actually seem to improve survival, either overall or cancer-related mortality.
Interesting.
Plus, extensive screening costs more, has risks from false positives, more tests, more anxiety, and involves radiation. So limited targeted screening is the recommended balance.
Right, avoiding the shotgun approach. Okay, finally in the section, thrombophilia testing. This seems to have sort of fallen out of favor for routine workup. Why is that, and who should get tested? This is a massive FRCS question. A 35-year-old man, first unprovoked DVT. Do you do thrombophilia screening? Which tests? When?
Yeah, a definite Viva staple. First, the main thrombophilias we think about. The hereditary ones like antithrombin, protein C, protein S deficiencies, factor V Leiden, prothrombin gene mutation. And acquired ones like antiphospholipid syndrome, APS.
So why not test everyone with a DVT for these?
Several reasons, really. First, for most patients, the result doesn't actually change the immediate management. You treat the DVT the same way initially, whether they have factor V Leiden or not.
Okay.
Second, it can cause a lot of anxiety for the patient, getting labeled with a clotting disorder, especially for the common lower-risk ones where many people never clot. Third, clinical factors like whether the DVT was unprovoked or if they've clotted before are often much better predictors of future risk than the test result itself. And finally, prevalence varies hugely by ethnicity. Factor V Leiden, for example, is common in Caucasians but rare elsewhere.
So testing isn't routine. When is it indicated? Who gets tested?
It's a very selective approach. The guidelines suggest testing in specific situations where the result might genuinely influence long-term decisions for the patient or their family. 1. Unprovoked DVT in younger patients, say under 45, who also have a strong first-degree family history of VTE, recommendation 11, helps identify high-risk families.
Okay.
2. DVT in an unusual site like cerebral veins or splashing veins in the abdomen. Thrombophilia is more likely there.
Makes sense.
3. Patients with unprovoked DVT where you're considering stopping anticoagulation, specifically testing for antiphospholipid antibodies, recommendation 12. Finding APS often means lifelong anticoagulation.
Right, that definitely changes things.
And 4, maybe women with DVT who also have a history of recurrent pregnancy loss or other related problems, again, looking for APS.
Okay, very targeted. What about the timing of the tests? This is crucial, isn't it? You can't just test any time.
Absolutely critical. You shouldn't test during the acute DVT phase or while the patient is on most anticoagulants, heparin, warfarin, DOACs. Many of these drugs interfere with the lab assays, especially the ones measuring protein levels or activity, giving false results.
So when do you test?
Ideally, you wait until they've finished their initial course of anticoagulation and have been off the drug for a period, usually at least 2 weeks after stopping warfarin, maybe 3 days or so after stopping a DOAC, though it varies. Genetic tests, like for factor V Leiden, can be done anytime because they look at DNA. And always, always repeat an abnormal protein-based test to confirm it before making big decisions.
Right. So, back to that 35-year-old man with his first unprovoked DVT. My answer would be, first, ask about family history. If strong, yes, consider testing. But explain you can't do the protein test reliably now while he's anticoagulated. You defer those until after his treatment course. You could do the genetic tests now, if indicated by family history. But the key is delaying the phenotypic assays.
Exactly. That's the safe and correct approach. #2, anticoagulation framework.
Okay, let's get into the core treatment, anticoagulation. The guidelines lay out distinct phases of treatment. Can you walk us through those? It helps structure how we think about it.
Sure. It's fundamental to break it down. There are basically three phases. First, the initial treatment phase. That's the first, say, 5 to 10 days. The goal here is rapid anticoagulation, stop the clot getting bigger, reduce the immediate PE risk, and help the acute symptoms.
Get it under control quickly.
Exactly. Then you move into the principal treatment phase. This is usually for 3 to 6 months. Here, the aim is preventing recurrence, helping the clot resolve, and trying to reduce the risk of long-term problems like post-thrombotic syndrome.
Right. And the third phase.
That's the extended anticoagulation treatment phase. This isn't for everyone. It's for patients who, after that initial 3-6 months, are still considered at high risk of having another clot. It's a long-term decision, balancing ongoing prevention against the bleeding risk.
That framework makes sense. Now, the drugs themselves, our options have really expanded. Can you give us a rundown, maybe comparing the key players, starting with the older ones that still have a role?
Definitely. The landscape has changed massively. Unfractionated heparin, UFH, used to be the mainstay. Now it's really for special situations. Severe kidney failure, patients on dialysis, maybe critically ill patients, or if you need to stop and start anticoagulation quickly around a procedure.
Because it has a short half-life.
Exactly. But it needs close monitoring with APTT levels, which is intensive.
Okay. Then low molecular weight heparins, LMWHs, enoxaparin, dalteparin.
Yeah, LMWHs.
Yeah.
Given by injection, usually once or twice a day, based on weight. Much more predictable than UFH. Routine monitoring, like anti-ACI levels, isn't usually needed.
Except in specific cases.
Except maybe in extremes of body weight. Significant kidney problems, though they're often safer than UFH in moderate kidney disease or during pregnancy.
Right. And fondaparinux.
Fondaparinux is a synthetic factor ASA inhibitor, also an injection, once a day, adjusted for weight, often used as an alternative to LMWH. The big thing to remember is you can't use it if the kidney function is poor, specifically CRCL less than 30. It builds up.
Good point. And vitamin K antagonists, VKAs. Warfarin, the old standard oral.
Warfarin inhibits vitamin K-dependent clotting factors. It worked, but the big drawback, and why DOACs took over, is the need for constant INR monitoring to keep it in the therapeutic range.
In all the interactions.
Exactly. Diet, tons of other drugs, liver function. It's complex to manage well.
Which brings us to the direct oral anticoagulants, DOACs, the real game changers. Can we break down the main ones? Dabigatran, rivaroxaban, apixaban, edoxaban. What are the key differences FRCS candidates must know?
Absolutely. These are crucial. DOACs directly target either factor thrombin or factor ZA, more predictable. Dabigatran, it's a direct thrombin inhibitor. The unique thing is it needs a lead-in 5 days of heparin first before you start it for DVT. Standard dose is 150 milligrams twice daily.
Dose reductions.
Yeah, consider 110 milligrams twice daily if over 80. Or on verapamil, maybe with moderate kidney impairment, CRCL 30-50. Definitely avoid if CRCL is under 30.
Okay. And the factors A inhibitors.
Right, these ABINs, edoxaban. Like dabigatran, it also needs that 5-day heparin lead-in. Standard dose 60 milligrams once daily. Also avoid if CRCL is very low, 15. Interestingly, also may be less effective if kidney function is too good, CRCL 95. Something seen in some trials.
That's unusual. What about apixaban and rivaroxaban? They don't need the heparin start, right?
Correct. Apixaban, no lead-in needed, has a loading dose. 10 milligrams twice daily for 7 days, then down to 5 milligrams twice daily. For kidney function, generally no specific dose cut for mild, moderate impairment in DVT, but use cautiously if CRCL is 15-29 and avoid below 15. Crucially, it has a lower 2.5 milligram a twice daily dose used for extended therapy.
And rivaroxaban.
Rivaroxaban. Also no leading needed. Loading dose is different. 15 milligrams twice daily for 3 weeks, then 20 milligrams once daily. Kidney function. Dose reduction to 15 milligrams once daily might be needed if CRCL is 15-49, balancing risks. Big point. Take it with food for best absorption. And like apixaban, it has a lower dose, 10 milligrams once daily for extended therapy.
Fantastic breakdown. Those details are vital. Now, duration of therapy. It hinges massively on whether the DVT was provoked or unprovoked, doesn't it?
Fundamentally, it's probably the biggest decision point after starting treatment. For provoked DVT caused by something temporary like major surgery, illness, maybe hormones, pregnancy, the risk of it coming back is much lower once that trigger is gone. So the guidelines for X14-15 are really clear. 3 months of anticoagulation is enough. Longer therapy doesn't help much with recurrence, but does increase bleeding risk.
And the drug choice for provoked DVT?
DOACs are preferred over VKAs, Rex16. The similar effectiveness, consistently lower bleeding risk, simpler too.
So provoked DVT, trigger gone, 3 months DOAC. Simple, but unprovoked DVT, that's a different beast entirely.
Completely different. No clear trigger means a high ongoing risk of recurrence. Can be over 40% at 10 years, especially in men. So the initial 3 months are the same. Treat the acute event. But for that principal phase, maybe out to 6 months, DOACs are again preferred over LMWH than VKA-REC19.
And this is where extended anticoagulation really becomes the key question, isn't it? Beyond that initial 3 to 6 months for unprovoked DVT.
Exactly. For unprovoked DVT, if the patient's bleeding risk is low or moderate, the guidelines recommend continuing anticoagulation long-term, REC21, with regular reviews, maybe yearly.
And the agent for that extended phase.
Again, DOACs should be considered over VKAs, REC22, mainly for the better safety profile. And here's a really important development. For patients needing extended therapy beyond 6 months, but maybe not at the absolute highest risk, like active cancer, you should strongly consider using a reduced dose of either apixaban, 2.5 milligrams twice daily, or rivaroxaban, 10 milligrams once daily, REC23.
Why the reduced dose?
Trials like Amplify-AXT and Einstein Choice showed these lower doses still offer good protection against recurrence, but with the significantly lower bleeding risk than full doses. It's a great option for long-term treatment.
What about aspirin, sometimes used for long-term prevention?
The guidelines say aspirin is not recommended, REC24. It's just much less effective than proper anticoagulants for preventing VTE recurrence. The lower bleeding risk doesn't make up for the lack of efficacy here.
Clear message there. So making that decision about extended therapy in unprovoked DVT, who gets it, who doesn't rely on assessing that recurrence versus bleeding risk, how do we do that practically? Are there scores?
Yeah, this is the risk stratification part. There are prediction scores, HERDO2, Vienna, -H using things like sex, D-dimer levels after treatment, DVT location, age, BMI. But they have limitations, often need validation.
So not always easy to apply.
Not always. Practically, it often comes down to a clinical judgment. Looking at the whole picture, was it proximal? Is the D-dimer still high? Male sex. Multiple unprovoked events. Weighing those against bleeding risk factors, age, comorbidities, other meds. Table 15 in the guidelines gives a useful framework. And crucially, you must reassess bleeding risk before continuing beyond 3 months, REC20. It's an ongoing conversation.
Okay, let's frame that as a Viva question. Patient, 55-year-old male, finished 6 months anticoagulation for an unprovoked proximal DVT. Fit and well otherwise. Factors for deciding on extended anticoagulation. What are the options, including doses?
Right. So for this 55-year-old male, factors. He's male, it was unprovoked, and it was proximal. All those point to a high risk of recurrence. His baseline bleeding risk seems low as he's fit and well. I'd confirm no prior bleeds, no kidney liver issues, no antiplatelets.
So high recurrence risk, low bleeding risk.
Exactly. Therefore, extended anticoagulation is strongly recommended. REC21. Options. 1. Continue a full-dose DOAC. AG, apixaban, 5 mg of BD, rivaroxaban, 20 mg of BD. Good protection. 2. But, given he's not super high risk, no cancer, etc., I'd strongly discuss and likely recommend a reduced-dose DOAC. Apixaban, 2.5 mg of BD, or rivaroxaban, 10 mg, REC23. Explain the trial evidence. Similar efficacy for preventing clots, but significantly less bleeding long-term. That's usually very appealing.
And aspirin.
Definitely not recommend aspirin. So it's just not effective enough here. REC24. Make it a shared decision, emphasizing regular review. Hashtag there's bleeding risk and reversal.
Okay, managing clots inevitably means thinking about bleeding. Let's talk bleeding risk and reversal. We know anticoagulants increase bleeding risk. How do we assess that risk, and what do we do when someone does bleed?
It's the constant seesaw, isn't it? Bleeding risk isn't uniform. It's often highest in the first few months, that front-loaded risk. The guidelines mention the ACCP criteria for factors that increase bleeding risk.
What sort of thing?
Things like older age, previous bleeds, active cancer, kidney or liver problems, low platelets, diabetes, being on antiplatelets too, poor INR control if on warfarin, recent surgery, false risk, heavy alcohol use. It's a long list.
A useful checklist.
Yeah.
But these scores aren't perfect predictors, are they?
No, that's the catch. They're not great at predicting exactly who will bleed. Their positive predictive value is often poor, but thinking through these factors is still vital for choosing the right drug, the right dose, the right duration for an individual patient. Your clinical judgment is key.
So when bleeding does happen or someone needs urgent surgery, reversal strategies. How do we reverse the different anticoagulants? Let's start old school.
Right. Unfractionated heparin, UFH, that's straightforward. Protamine sulfate works quickly, very effective.
LMWHs.
Protamine sulfate again. But it only partially reverses LMWH, especially the anti-Zeca activity. Not a complete fix.
Fondaparinux.
No specific antidote for fondaparinux currently. You just stop it and provide supportive care.
Okay. Vitamin K antagonists, VKAs, like warfarin. Still common.
For warfarin, depends on urgency. Vitamin K works, but its slow takes maybe 24 hours for the INR to normalize fully. For urgent, severe bleeding, You need prothrombin complex concentrates, PCCs. Four-factor PCCs are preferred over three-factor or FFP because they replace all the vitamin K-dependent factors quickly. There are good national guidelines on exactly how to dose based on INR and bleeding.
Good point. Now, the DOACs. Reversal agents for these have been a major step forward, haven't they?
Huge step. For dabigatran, the thrombin inhibitor, the specific antidote is adoricizumab. It's an antibody fragment, binds dabigatran incredibly tightly, works almost instantly, very effective for major bleeding or urgent procedures.
And for the factor A set inhibitors, rivaroxaban, apixaban, edoxaban.
The specific antidote is andexin alpha. It's like a decoy factor Zaxaprotein mops up the drug. Currently licensed for reversing rivaroxaban and apixaban. Dosing depends on which drug they took and when. If andexanet isn't available, or for edoxaban, you might use PCCs as the non-specific reversal agent.
Practically speaking, though, with DOACs having shorter half-lives than warfarin, do you always need an antidote for surgery?
Great question. Often, no. For elective surgery, because their effect wears off relatively quickly, you can usually just stop the DOAC for a defined period beforehand, maybe 24 to 72 hours, depending on the DOAC, kidney function, procedure risk. This often avoids needing complex bridging anticoagulation.
But for life-threatening bleeding?
Then yes, absolutely use the specific antidotes, idurcizumab or andexanet alpha or PCCs if needed, alongside all the usual supportive measures. Stop the drug, fluids, control the source.
Okay, let's touch on a specific complication, heparin-induced thrombocytopenia, HIT. What is it, how do you spot it, and what's the management? It's rare but serious.
Very serious. HIT is an immune reaction. The body makes antibodies against a complex of heparin and a platelet protein called platelet factor 4, PF4. This paradoxically activates platelets, causing thrombocytopenia, low platelets, but also, critically, making the patient highly prothrombotic, prone to new clots.
And risk factors.
It's much more common with unfractionated heparin than LMWH. Vonaparinex doesn't cause it. Surgical patients are also at higher risk than medical patients.
Diagnosis. How do you suspect it?
You use the 4T score. It's a clinical scoring system looking at four things: thrombocytopenia, how much the platelets dropped; timing, when it happened after starting heparin; thrombosis, new clots or skin reactions; and excluding alternative causes. A low score makes HIT very unlikely.
And if the 4T score is intermediate or high, what's the absolute first step?
Stop all heparin immediately. Every source, infusions, flushes, coated lines, everything.
And then what? You need an anticoagulant.
You must start a non-heparin anticoagulant right away. Options are direct thrombin inhibitors like argatroban, good, kidneys are bad as it's cleared by the liver, or danaproid, needs monitoring. Biolirudin is another. Once the platelet count starts to recover, you can think about starting warfarin, but you must overlap it with the non-heparin agent for several days to avoid skin necrosis. #TACTED-by-V. Interventions beyond anticoagulation.
Moving beyond drugs, what about other interventions? Let's tackle inferior vena cava, IVC filters. Their use seems much more restricted now. What's the evidence say? Thinking about trials like PREPIC, another classic Viva topic.
Yeah, the story of IVC filters is a great example of evidence-changing practice. The current guideline stance is very clear. Routine use of IVC filters is not recommended if the patient can be safely anticoagulated for their DVT. Recommendation 30.
And the evidence driving that?
Primarily the PREPIC trial. It randomized DVT patients who were getting anticoagulation to either get a permanent filter or not. Short-term filters reduce PE rates a bit, but the longer-term follow-up, out to 8 years, was the kicker.
What did that show?
It showed that while the small reduction in PE persisted, there was a significant increase in recurrent DVT in the filter group, and crucially, no survival benefit. Later trials like Filter PVI also showed no mortality difference.
So less PE, but more DVT, no longer life expectancy. A poor trade-off. When are they still indicated then?
Only in a very specific niche. Patients with proximal DVT who have an absolute contraindication to anticoagulation, recommendation 29. Think active, life-threatening bleeding, or maybe just after major neurosurgery where anticoagulation is impossible.
And even then?
Even then, temporary, retrievable filters are preferred. Get them out as soon as anticoagulation becomes safe. Permanent filters have long-term risks, fracture, migration, clogging the vena cava, and that increased DVT risk. So filters are a safety net, but only when there's absolutely no alternative.
Very clear. Okay, compression therapy. Stockings, bandages. What's the latest thinking on their role in acute DVT, and particularly in preventing post-thrombotic syndrome, PTS? What's changed?
Compression, always debated. First, quick safety points.
Yeah.
Don't use it severe arterial disease, ABI 0.5, or severe heart failure. Side effects are usually minor skin issues.
So for the acute DVT itself, what's the recommendation?
For acute DVT, the guidelines, Rec. 31, recommend early compression, ideally within 24 hours, using bandages or strong stockings, 30-40 millimeter gauge. The main reason is to reduce acute pain and swelling, and maybe residual clot burden. It makes the leg feel better.
But does it stop the clot coming back?
No. Important point, acute compression does not reduce the risk of recurrent DVT. It's purely for symptom control and reducing residual clot.
Okay. What about the long game preventing post-thrombotic syndrome, PTS, that chronic leg swelling, cane, skin changes?
PTS is a huge issue, affects up to half of DVT patients long term. We measure it with the Villalta scale. The evidence on stockings for preventing PTS has been messy. The big SOX trial was negative, but other studies and a big Cochrane meta-analysis do suggest an overall benefit, maybe around a 38% risk reduction. So the guidelines still say below-knee compression stockings should be considered to reduce PTS risk, Rec. 32.
Considered, not definitively recommended for everyone.
Exactly. It's a consider based on that conflicting evidence. But again, stockings do not prevent recurrent DVT.
Right. And what's the big change regarding duration? We used to tell people to wear them for ages.
That's the key evolution. The ideal DVT trial was practice-changing here. It showed that an individualized duration, stopping stockings based on the Villalta score after 6-12 months if symptoms were controlled, was just as good as wearing them for a fixed 2 years.
So we can stop them much earlier for many patients.
Yes, if the Villalta score is low, symptoms are gone, you can often stop them at 6 or 12 months. It's more patient-friendly, better compliance, saves cost, moving away from dogma to tailored care.
Great example. Okay, Viva question. Patient with new proximal DVT asks about stockings. What do you say about acute management, PTS prevention, and duration?
I'd say, for your immediate pain and swelling, wearing compression, starting now, will likely help significantly. Rec. 31. It won't stop another clot, but it'll make your leg feel better. For the long term, to reduce the risk of chronic problems like persistent swelling or skin changes called post-thrombotic syndrome, we should consider you wearing below-knee stockings. Rec. 32. The evidence is a bit mixed, but overall suggests a benefit. The good news is we probably won't need you to wear them for years. Based on recent trials like Ideal DVT, we'll check your leg regularly using a score, and if things are looking good after 6 to 12 months, we can likely stop the stockings then.
Perfect. Now the really aggressive stuff. Early thrombus removal and stenting, CDT, PCDT. Why even think about this when anticoagulation works for most?
The rationale comes from understanding PPS. We know that leftover clot and damaged vein valves are the main cause, especially with big iliofemoral DVTs. The idea of the open vein hypothesis is if you get the clot out early, you preserve the vein, preserve the valves, and hopefully prevent or reduce the severity of PTS later on.
Makes sense physiologically. What are the techniques?
Few main ones. Surgical thrombectomy. Open surgery, rarely done now, mostly historical interest. Catheter-directed thrombolysis, CDT. Threading a catheter into the clot, dripping in clot-busting drugs like alteplase. Often needs hours or days. Allows you to do venography and stent any blockages afterwards. Bleeding is the main risk. Pharmacomechanical CDT, PCDT, combines the clot-busting drug with a device that physically breaks up or sucks out the clot. Aims to be faster, maybe use less drug.
Sounds good in theory, but the RCT evidence, I know it's been a bit conflicting. Cavant versus ATTRACT.
Exactly. This is where it gets complex and vital for the exam. The Cavant study. An earlier trial looked positive, showed CDT significantly reduced PTS compared to anticoagulation alone, both at 2 years and 5 years. The NNT looked pretty good, seemed cost-effective.
But then ATTRACT came along.
But then the bigger ATTRACT study. Randomized patients with proximal DVT to PCDT plus anticoagulation or anticoagulation alone. The main outcome is any PTS. And ATTRACT found no difference in any PTS between the groups. That was a big shock.
No difference at all.
No difference in the primary endpoint of any PTS. However, ATTRACT did show PCDT significantly reduced moderate to severe PTS. So maybe it helps prevent the worst outcomes. It also improved acute pain and swelling, but it significantly increased major bleeding, 1.7% moderate, 0.3%.
And other trials.
The TIVA study also found no difference in overall PTS. A meta-analysis combining them suggests overall, yes, thrombus removal probably reduces any PTS and especially moderate to severe PTS, but at the cost of a 5-fold increase in major bleeding.
Wow, 5-fold. That's huge. So benefit for severe PTS, but not overall, and a big bleeding price. How do we apply this clinically? What were the trial limitations?
Limitations included maybe not enough stenting in some trials, older devices used. The conflicting results are tricky, but the bottom line is the high bleeding risk forces us to be incredibly selective. It's only worth considering if the potential gain, preventing severe, life-altering PTS, is high and the bleeding risk is low.
So indications and patient selection are absolutely paramount. Who gets considered for early thrombus removal?
The guidelines, Rec 34, say, consider it only in selected patients with symptomatic iliofemoral DVT. Who are they? Typically young, active patients with an acute clot, 14 days, extensive iliofemoral involvement, severe symptoms, maybe early phlegmasia, who are at high risk of bad PTS and low risk of bleeding.
And who definitely doesn't get it?
Definitely not recommended for DVT. That's only in the femoral, popliteal, or calf veins, Rec 35. The risks just aren't justified for less extensive clots where outcomes with anticoagulation alone are generally good.
What about stenting after you remove the clot? Is that common? Does it change anticoagulation?
Stenting is often needed, especially in iliofemoral DVT, because there's often an underlying compression, like May-Thurner syndrome. You clear the clot, then stent the narrowed bit to keep it open. But stenting does not mean less anticoagulation. You need at least the standard duration, maybe longer depending on the case, Rec 36.
Okay, challenging Viva scenario. Young patient, 28 years old, acute, expensive left iliofemoral DVT, leg is very swollen, painful, looks pale, early phlegmasia, albedolens. Outline your management.
All right, this is an emergency. Immediate actions. Start therapeutic heparin, LMWH or UFH straight away. Elevate the leg aggressively, give fluids. Given the extensive iliofemoral DVT, the severe symptoms, the phlegmasia, and the patient being young with likely low bleeding risk, this is exactly the scenario where early thrombus removal should be strongly considered. I'd urgently discuss with interventional radiology or vascular surgery for CDT or PCDT.
Rationale.
High risk of severe PTS, potential limb threat. The potential benefit of reducing severe PTS and improving acute symptoms likely outweighs the bleeding risk in this specific patient. I'd counsel them about the bleeding risk, citing attractee, but frame it against preventing long-term disability or limb loss. Following thrombolysis, investigate for underlying stenosis, like May-Thurner, and likely proceed to iliac vein stenting if found. Long-term anticoagulation needed, probably extended duration. Close follow-up essential, #TAG-V. Special scenarios.
Excellent. Let's cover some other specific situations. What about calf deep vein thrombosis, distal DVT? Used to be treated less aggressively. What's the current view?
Yeah, distal DVTs were often seen as less serious. They are less likely to propagate proximally, maybe 9% risk, or cause PE around 1.5% compared to proximal DVT. But the guidelines, Rec 38, now lean towards treating them more consistently. Meta-analyses show anticoagulation reduces recurrence and PE risk without much increase in major bleeding.
So what's the recommended treatment?
Recommendation is anticoagulation for 3 months, same as provoked proximal DVT. This is better than shorter durations or just observing.
And if you don't anticoagulate for some reason?
If anticoagulation isn't used, then you must do clinical review and repeat the whole leg ultrasound after about a week, Rec 42, to check for proximal extension. It's a safety net.
Drug choice.
DOACs are recommended over LMWHVKA, Rec 40. Extrapolating from proximal DVT data, consider extended therapy if it was unprovoked, and there are other risk factors.
Okay, so take calf DVT seriously. Now, they're real emergencies. Phlegmasia albedolens and phlegmasia ceruleadolens. How do we spot these, and what's the immediate plan?
These are limb-threatening, need instant recognition. Phlegmasia albedolens, white leg. Massive swelling pain, usually from iliofemoral DVT. Deep veins blocked, but arterial inflow is okay initially, hence the pale look. High risk of progressing. Phlegmasia ceruleadolens, blue leg. Much worse, thankfully rarer. Total venous outflow obstruction, iliacs, cava, maybe. Clot extends everywhere, deep in superficial veins, causes massive congestion, cyanosis, the blue, severe ischemic pain because the swelling compromises arterial flow. High risk of gangrene, compartment syndrome, shock, PE. Mortality is high, amputation risk significant.
A true vascular catastrophe.
Management. Immediate, aggressive. Start therapeutic heparin instantly. Elevate the leg high, push fluids. But anticoagulation alone often isn't enough here. Given the limb threat, aggressive early thrombus removal is usually indicated CDT, PCDT, maybe surgery, plus iliac stenting if needed, and urgent fasciotomy if compartment syndrome develops. Principles are similar to severe iliofemoral DVT, but the urgency is even higher.
Right. What about superficial vein thrombosis, SVT, often dismissed as just phlebitis? What's the real risk, and how should we manage it, especially if it's near the deep junction? Viva question. How do you manage SVT nearing the saphenofemoral junction? What's the thromboembolic risk?
Another condition that's definitely not benign, the risk is real. About 25% of SVT patients have a concurrent DVT or PE when diagnosed, and around 10% develop a new VTE event within 3 months. So not trivial, Diagnosis clinical, but whole leg ultrasound, WLUS, is recommended Rec 43, essential to check the extent and, crucially, rule out a coexisting DVT, which is present in up to half of cases.
So always scan. What about treatment, anticoagulation?
Yes. Depends on location and size. If the SVT is at least 5 centimeters along BUT, more than 3 centimeters away from the deep junction, the recommendation is fondaparinux 2.5 milligrams daily for 45 days, Rec 47. Based on the Callisto trial, intermediate dose LMWH is an alternative, Rec 46.
But what if it's close to the deep system, like in the VIVA question, near the SFJ?
If the SVT extends to within 3 centimeters of the deep junction, then therapeutic anticoagulation is recommended, Rec 48. Just like a DVT, usually for 3 months, the risk of it extending into the deep system is much higher.
Any role for DOACs like rivaroxaban?
The surprise trial showed rivaroxaban was non-inferior to fondaparinux, so it's an option, potentially more convenient being oral, but SVT isn't always a licensed indication yet.
And surgery, ablating the vein.
Maybe consider ablation later, months after the acute event has settled, Rec 51, if there's underlying venous reflux. Definitely not for treating the acute SVT itself.
Okay, so for that VIVA patient with SVT near the SFJ, get a WLUS to check for DVT. Because it's close to the junction, start therapeutic anticoagulation for at least 3 months. Clear. Now, cancer-associated deep vein thrombosis, CAVT, high recurrence, high bleeding. What's the latest on LMWH versus DOACs? The evidence keeps shifting.
It's a really challenging group. High VTE recurrence, 20% at 1 year. High bleeding, 12%, often recur while on treatment. LMWH has been the gold standard for years based on solid evidence.
But DOACs have entered the fray. What did the big trials show? Hokusai VTE cancer, Selected D, Caravaggio.
Those trials directly compared DOACs, edoxaban, rivaroxaban, apixaban, against dalteparin, LMWH. Key findings. DOAs are generally better at preventing recurrent VTE than LMWH in cancer patients. That's a big plus.
But the downside?
The downside is a signal, often non-significant but worrying, towards increased major bleeding with some DOACs, especially GI bleeding, in patients with GI or GU cancers. Edoxaban and rivaroxaban showed this more clearly. Apixaban, in its trials, ATOM, VTE, Caravaggio, seemed to have similar bleeding rates to LMWH, which is encouraging.
So better efficacy, but potentially more bleeding depending on the DOAC and the cancer type. How did the guidelines navigate this?
They're cautious and nuanced. LMWH is still recommended for initial and principal phase treatment, RET 63, especially if the cancer is GI-GU or high bleeding risk. It's the tried and tested safe option.
But DOACs aren't ruled out.
No. For extended treatment beyond 3 to 6 months, switching from LMWH to an oral agent, VKA or DOAC, is fine, REC 64. And importantly, approved DOAs can be considered for initial, principal, and extended treatment in selected patients, specifically those whose cancer is not GI or GU and who don't have other high bleeding risks, REC 65. So you can use DOACs up front, but patient selection is absolutely critical.
Okay, final VIVA scenario. Patient with active pancreatic cancer gets a DVT. Pros and cons of DOAC versus LMWH, cite evidence, selection criteria.
All right, pancreatic cancer and high-risk GI malignancy. Therefore, my initial choice would be LMWH. Pros of LMWH. Establish safety in CAGT, especially high bleeding risk cancers like pancreatic, REC 63. Trials showed DOACs like edoxaban rivaroxaban had higher GI bleeding trends in these groups. Cons of LMWH. Injections may be less convenient long-term. Pros of DOAC. Potentially better VTE prevention based on overall trial data, oral convenience. Cons of DOAC in this patient. Significantly increased concern for major GI bleeding given the pancreatic cancer location based on Hokusai's Select-D signals. This patient does not meet the selection criteria for upfront DOAC, i.e. not a non-GI-GU cancer, REC 65. Conclusion. For this patient, the bleeding risk with a DOAC is too concerning. LMWH is the safer guideline preferred initial choice.
Crystal clear. Lastly, quick hits on other special populations. Pregnancy, children, renal impairment, extremes of body weight. Key points.
Okay, rapid fire. Pregnancy. High VTE risk. D-dimer wells useless. REC 60. Diagnosed with WLUS. Treat with LMWH throughout and 6 weeks postpartum. REC 61. VCANS DOACs contraindicated. Children. Low incidence but rising. Need specialist pediatric hemostasis input. REC 59. LMWH UFH standard. Rivaroxaban emerging. Renal impairment. Increased VTE and bleeding risk. Need dose adjustments monitoring for most drugs. REC 70-71. Avoid LMWH FONDOACs if CRCL 15. UFH VKA traditional for severe CKD, DOACs usable dose adjustments in mild moderate CKD, extremes of body weight, adjust UFH LMWH Fonda dose by weight, REC 72, maybe monitor anti-Zexa for LMWH. DOAC is generally okay across a range, but caution needed in extreme obesity, for example, BMI 40, less data. #6 key take-home messages for a day one vascular consultant.
Okay, we have covered a huge amount today, really dissecting these ESVS 2021 guidelines. For someone listening, maybe about to sit FRCS, about to be a day one consultant, what are the absolute key take-home messages, the non-negotiables?
All right, 5 critical points to nail down. 1. DOACs are your default for most DVTs, but know the exceptions. Get comfortable using DOACs first line for provoked and unprovoked DVT. They're generally safer and easier than VKAs, but be razor sharp on when not to use them. Pregnancy, severe renal failure, maybe high-risk GIGU cancers initially. LMWH is still vital in those groups.
Right. Default, but not universal.
Exactly. 2. Anticoagulation duration is tailored. Assess risk dynamically. Stop thinking fixed durations for everyone. Unprovoked DVT. Assess recurrence versus bleeding risk actively. Consider indefinite therapy. And use reduced-dose DOACs long-term when appropriate. Provoked DVT. Stick to 3 months if the trigger's gone.
Tailoring is key.
3. Early thrombus removal is highly selective, not routine. CDTP-CT is only for specific patients, young, active, severe iliofemoral DVT, high PTS risk, low bleeding risk. Understand it's a trade-off.
Right.
Potential benefit for severe PTS versus definite increased bleeding risk. It's not for most proximal DVTs.
Niche, not standard.
4. Treat distal DVT and SVT seriously. Don't dismiss CAF DVTs or SVTs. Both need proper assessment, including WLUS, and usually anticoagulation to prevent VTE complications. They are not benign.
Investigate properly.
5. Special populations need special care, often teamwork. Cancer, pregnancy, kidney disease, thrombophilia. These aren't straightforward. Management often involves LMWH initially, specific DOAC considerations, dose adjustments, and importantly, collaborating with other specialists like hematologists or obstetricians.
Great summary. That really distills it down brilliantly. We've gone through diagnosis, drugs, interventions, special cases, hopefully giving you the evidence and the reasoning you need for the exam, but more importantly, for looking after patients confidently. The aim wasn't just facts, but understanding the why.
And knowing the why lets you apply the knowledge flexibly, which is what being a consultant is all about.
Yeah.
The field keeps moving too. It really does. Which leads to a final thought for you, our listener, to take away. With VTE management evolving so fast, new drugs, new devices, better risk prediction, maybe what do you think the next big game changer will be? What current challenge or uncertainty might become tomorrow's standard practice?
Something to ponder.
Absolutely. Keep asking questions, keep learning, keep focused on patient care. That's it for this deep dive. Thanks for joining us.
See you next time.